Thank you to Professor Yakuba and Professor Bono for the invitation and the topic of this talk, which is quite clear, is intravascular ultrasound and OCT going to stand out these multiple intravascular modalities, some of which are totally gone, angioscopy, nobody truly uses it, or will we need some new addition to make it more viable, as we have heard in the excellent introduction of Professor Bono? I think it is a question that we have to ask ourselves, because these are not new techniques. Intravascular ultrasound, I was playing with this type of images 25 years ago, and soon after these experiments and these validation studies became a clinically applicable technique. So how comes that a technique that was introduced 25 years ago still in Europe has a penetration far less than 10%? The UK is probably one of the countries with the highest penetration, is 6% last year in the BCS registry. If you look in guidelines, we have class 1 for FFR, but for intravascular ultrasound, you have 2B in the best scenario for left main in the European guidelines, and not much more in nothing for OCT. The reason why intravascular ultrasound is still around is essentially this application that came up soon after its introduction, coming from the group of Colombo, showing that when you implant stents with 6-8 atmospheres, that was the practice at the time, your result is horrible. You have only in 30% of the times what you want to have a proper expansion. Angiographically, it looks fine, but if you look from inside, intravascular ultrasound shows this stent that is still totally unexpanded and this large plaque burden, explaining why all these stents had extremely high thrombosis rate despite a high level of anticoagulation. While doing the job properly, you can reduce the anticoagulation, and you all know the story, with the help also of other antiplatelets. Many people say, well, right, this is, we have learned the lesson, we just use 14, 16, 20 atmospheres, and we've got the job done. I personally don't do that. Also, Dr. Colombo, who probably has some experience with looking at ultrasound images, uses around 60% of the times intravascular ultrasound, like myself. I'll give you just an example in the modern drug-eluting stent era, a quite severe lesion of the mid-right coronary artery in an extremely diffuse disease in a diabetic patient, no LED stenosis, so we are not speaking of appropriateness of doing PCI or CABG. Relatively young patient. You deploy your stent at 14 atmospheres, is a large stent, certainly adequate for the dimension of this dominant right coronary artery, 3.5 millimeter, looks angiographically fine, is possibly somehow covered also by this branch. This is the minimal cross-section area within the stent, is very poor. 4.3 square millimeter is associated in multiple trials to poor prognosis in terms of high stent thrombosis and higher revascularization rate, especially when you compare with a nearby segment, you see is almost half of it. Not only, if you consider this area, you do have a fairly large plaque burden, a small area, and having this at the edge of a stent implanted probably is not a good idea. And definitely you can find area downstream in the vessel which are more normal looking. So an additional stent here, nicely expanded, high pressure, 24 atmospheres for this segment with a 3.5 short balloon, makes a complete difference in the image that you see with this nice, regular, uniform lumen. And it's hard to believe that this will not translate into clinical differences in outcome. Unfortunately, it's hard to believe, but we don't have data, and coming immediately after Professor Bono with his wealth of data on non-invasive imaging and New England Journal of Medicine randomized trials, I feel embarrassed to present a meta-analysis of relatively small randomized trials that belong to the pre-drug-eluting stents era, and have this great variability of results. You do demonstrate that you can achieve a larger lumen when you do use intravascular ultrasound to deploy your stents. However, repeated revascularization, the outcome is variable and no difference in the largest of this trial, which is the trial we did in Europe with Professor Mths OCT, and overall MACE, you barely get to a significance, but a confidence interval that almost approach the unity, and again, the largest of this trial going on the wrong side of the equivalency line. If you look at the criteria that were used in OPTICUS, again, the largest of this randomized trial, we try to simplify to a minimum them just to show apposition, to show good expansion of the stent compared with the reference proximal or distal. When we reanalyzed the intravascular ultrasound images independently, we saw that the investigators at the time of the procedure achieved this criteria in less than 60% of the time. So, of course, they get a slightly better lumen, but they don't get what you want, in part because sometimes it's difficult to achieve, in part because intravascular ultrasound is not the easiest technique to analyze immediately online in your cath lab if you want to do your procedure in 1 hour rather than in 3 hours, having fellows going in and out, making measurements. In the drug-eluting stent era, we have some more encouraging data. Numbers have become larger. There are new players like, for instance, the Korean groups that showed in left main coronary artery disease that 600 patients treated with intravascular ultrasound guidance had a mortality benefit at 3 years compared with 210 that did not receive intravascular ultrasound, and this remains significant also after having adjusting for confounders. Of course, it's not a randomized trial. You may ask yourself if the standard in that center is use of IVUS, why IVUS was not used in these 200 patients, and they may have some characteristics of acuteness or complexity that may make them more prone to have higher mortality. If you look to non-randomized trial and the single randomized trial that has been reported, the number is impressive, but again, putting together methodologically not sound data not necessarily make the data stronger. And what you do have is, again, intravascular ultrasound guidance tends to reduce mortality and stent thrombosis without, however, an impact in overall MACE and myocardial infarction in particular. If you consider one of the best of these non-randomized trials that properly matched the population 460 with and without intravascular ultrasound, this Korean excellent trial, you have a price to pay for this high pressure dilatation, which is a higher incidence of periprocedural myocardial infarction. You may say slight increase of troponin doesn't affect long-term prognosis. This is very controversial. There is no difference in late, however, spontaneous myocardial infarction. So you pay a price, but you don't really gain, and same for other parameters like stent thrombosis. This is, in fact, shifting from the outcome related to the treatment of the lesion to the outcome related to the potential additional information that intravascular ultrasound provides on other arteries. Patients in which you did your job on the culprit lesion properly, and you examine then with intravascular ultrasound with the added benefit of a virtual histology imaging to assess the various components, fibrotic plaque and lipid-laden plaque, the first 6 centimeters of the other 2 arteries, assessing them also with QCA and measuring areas. The outcome, I think, is very interesting. Besides the intravascular ultrasound story that I'm going to summarize in my next slide, we all concentrate on our culprit lesion to do our job well, but new events at 3 years come from the culprit lesion that we treat with a stent only in 13% of the times. The remaining events that contribute to an overall MACE of 20.4% come from other arteries that were not, other lesions that were not treated, 11.6%. Probably, if you consider diabetic patients or patients with multiple risk factors, this increases, and this explains why surgery, when you shoot to all arteries, achieved a better goal than when you just treat the tip of the iceberg, so the most severe plaque in high-risk conditions such as diabetes. But let's come back to the additional information that intravascular ultrasound offers for non-culprit segments. Sync-up fibroatheroma, this condition that has been clarified yesterday by Professor Falk as being the underlying cause of the majority of our acute coronary syndrome, when assessed with intravascular ultrasound, increases 3 to 4 times the number of events, but still, considering that you have to treat all these plaques with, for instance, a stent, you don't have much better method right now, at least invasively, to treat these vessels, doesn't make sense. It's only 4.4% of events at 3.4 years. If you add to this plaque burden more than 70% and a small lumen area of less than 4 square millimeters, you increase quite significantly, and you may ask yourself whether you really need to wait that this plaque become physiologically impairing flow to treat it, 17.2% of events, 1.8 if you don't have these 3 characteristics. And there is a series of shades of gray for presence of these characteristics combined. You may ask yourself whether the fact that presence of vulnerable plaque is not so highly predictive is also related to the relative limitation of the technique we use. We use mainly virtual histology, which is somehow not totally proven for the ability to assess the characteristics of the tissue, but also intravascular ultrasound in general is unable to measure the thickness of the cap. So the assumption to call a plaque vulnerable is that when you don't have anything visible between the lipid-laden plaque and the lumen, this is a sync-up fibroatheroma, being 100 micron, the resolution of intravascular ultrasound, and being 60, the cutoff criteria for sync-up fibroatheroma. You understand that's a very poor definition. So maybe it's the time, if you want to achieve this goal, to move to a different technique, optical coherence tomography. This is the consensus of a group of more than 250 investigators, scientists, and cardiologists who define what with OCT is possible, and as you can see, they gave a high level of evidence to the ability of optical coherence tomography, thanks to this high resolution, to identify the thickness of the cap and the presence of this large lipid-laden plaque. You can't measure its thickness, you don't see the far wall. However, this information is not present with other techniques. I'm somehow sorry to say that I decided to skip a lot of other slides on this particular aspect, because I know this afternoon Dr. Antoniucci will speak about thrombus burden inside plaques with acute coronary syndrome, but I'm more than happy to rediscuss and come back to this in the question time. So intravascular ultrasound and OCT, the difference is wavelengths and consequently resolution from 10 to 100 with micron with ultrasound, axial similar for lateral resolution, but the difference is also acquisition speed. With a rotation speed that is approaching for the Terumo system 160 light labs 100, you can have an average speed of your pullback of 20 millimeters per second. That means that in 5 seconds you can acquire 10 centimeters of vessel. The entire epicardial coronary artery is imaged, which is not the case with ultrasound. You slow pull back 0.5 millimeters. You have thousands of cross-sections to slowly see during the acquisition. The exquisite characteristics and resolution of OCT is of particular importance when you want to assess conditions like apposition or thin coverage of struts. Let's speak of apposition, and let's speak of a new type of stent, biodegradable stents. You see individually these struts and their characteristics, thick struts, as you know, with the presence of some areas of malapposition that are totally unachievable with the corresponding intravascular ultrasound image. So the superiority of OCT for the assessment of thin coverage of drug-eluting stent or apposition or any stents, and in particular of these devices that has been shown disappears much more efficiently when they are properly in contact with the vessel wall, is far superior with the optical coherence tomography. The other advantage of optical coherence tomography is that there is such a sharp delineation of the lumen wall interface, even when they have a complex wall interface, such as after balloon dilatation. You need to pre-dilate. You can't assess this with OCT before pre-dilatation because there will be no flow here, and you need to drive the contrast out by continuous injection. When you have done that, you can have instantaneously at the end of your pullback an assessment of the diameter length function throughout the disease segment, and when you do it after stent implantation and post-dilatation, you can immediately say, I've done a good job, and this is likely to be a value that resist the assessment of an independent core lab, and the probability that with OCT you do a proper expansion of your stent is far above the 60% you have seen in the OPTICUS study with intravascular ultrasound. In the same patient, assessment of this much more complex lesion in the LAD, and you have the ability also to assess not only minimal cross-section area, but the status of the various bifurcation. You will never go to 4 millimeter if you don't do an imaging technique for this proximal circ. You do see that in the left main not treated there is a large eccentric lipid-laden plaque with a thick cap atheroma. In one patient, 11 pullbacks and OCT assessment in 3 vessels, quite a lot of contrast, but you don't do conventional angiography, you just insert your probe, and this is your assessment, OCT and angio simultaneously. I'm convinced that you make a difference, and we were the first to show 135 patients treated with OCT-guided stent implantation, but now there is a larger study, Italian, CLI OPCI study, 333 angiographic guided patients compared with 335 patients studied guided with OCT, showing in a multi-center setting a difference in outcome related to major events such as cardiac death, borderline for myocardial infarction, and stent thrombosis. You may say it's not a randomized trial. The criteria used for expansion were not uniform along the population treated, but I think is an important information that tells you is not purely a research technique, is applicable in a multitude of laboratories due to the improvement in technology allowed by frequency domain OCT. Another condition where there is no other way to do a good job without OCT are bifurcations. It's been shown over and over that if you cross your struts doing provisional stenting in the most distal cell, you achieve a much better opening of the stent towards the side branch than when you cross in the more proximal cells. But this, in a way, was just wishful thinking of the way we were doing, pulling our wire back and trying to fall immediately into the most distal cell, but there is no way angiographically to say where you are with your wire, and the same with intravascular ultrasound. With OCT, even without this three-dimensional imaging, you do have the possibility to see that proximally you are still with the lumen, with the second wire, and you cross at the distal edge of the vessel. If you do so, you achieve this fantastic opening with no struts in the middle of the lumen. And apposition certainly is a criteria that you prefer towards the presence of cells in the middle of the lumen that have a much lower and much longer time to coverage. We did show in this pilot series published last year 12 patients with OCT guiding recrossing of bifurcations versus our historical series of 40, that you can achieve this job in all cases. In 2/3 of the times you already are with your wire in the proper distal cell. In 1/4, a second attempt will lead to success. You may need 4 OCT pullbacks to get success in this particular unlucky patient. But when you have done that, you reduce the percent of malapposition at the site of the bifurcation from more than 40% of the struts to less than 10% of the struts. Of course, you need a much larger trial to come to a confirmation that is of clinical benefit. Guidance of treatment of restenosis, maybe we don't see this type of restenosis much in the drug-eluting stent era, but with OCT, this is one of the few conditions where you can see quite well through this homogeneous plaque, and the struts of the stent are such a powerful reflector that you can properly measure the stent to stent, the strut to strut diameter, guide the choice of appropriately sized cutting balloons, and if you are able to denude the plaque to get your cutter, your blade through the strut of the stent, you can achieve not only a better result by expansion, but by extrusion of the plaque, so you truly have a reduction of the neointimal area by doing that, achieving an expansion of the lumen much better than with conventional technique with high pressure balloon dilatation and restenting. Late results after drug-eluting stents are more related to coverage than to restenosis, however. We did a trial studying with OCT at 9 and 36 months conventional sirolimus-eluting Cypher stents and second generation biolimus-eluting biometric stents. Is a much more pleasant image when you have thin struts like the biometrics and this cobblestone appearance with the thick Cypher. Still, we noticed that if at 9 months there was a difference in favor of the biometric stents, over time there was a catch-up phenomenon with small but continuous coverage of the majority of the struts for both stents. And this may explain why the stent thrombosis issue tends to fade away and disappear over time. You see sirolimus paclitaxel eluting stents have a high percentage of uncovered struts in the first year, but then tend to catch up with second generation drug-eluting stents. So why do we have still acute phenomena within the stented segment in beyond 1-2 years after implantation? That's a new chapter I have no time to discuss in detail, but neoatherosclerosis within stents is a sort of paradox. You use stents to passivate the plaque, but somehow you stimulate the growth of plaque that are also potential of rupture with classical foamy macrophages. My conclusion, and this is in a paper that has been published in the first edition of this new European Heart Journal of Cardiovascular Imaging that wants to deal not only with non-invasive but also invasive imaging, is that I think it's fair to say that OCT and intravascular ultrasound are not only play tool generating pretty pictures. This is ungenerous. We have seen some valid concept of clinical application. However, we still need an enormous amount of work to validate the clinical relevance of this very initial series that I presented. Thank you.
Carlo, really elegant presentation. One other area that you mentioned in your introduction was the use of spectroscopy, near-infrared spectroscopy. Have you had experience with this tool, and do you think there's value in identifying plaque inflammation?
Well, more than inflammation is the holy grail to show cholesterol, and in a quantitative fashion. What is somewhat missing for somebody who is used to images rather than a yes-no answer is where is the cholesterol and the lipids located within the plaque, because thickness of the cap has a role, obviously, and whether this is uniformly distributed or is in a core with the potential of rupture may make a tremendous difference. However, there are, and I showed just an image at the beginning, you did show also similar images, combined intravascular ultrasound spectroscopy is already in clinical testing, and I think may solve this drawback of the technique. There are very limited experiences so far. However, there are studies, the yellow study in New York and other centers, showing that you predict the amount of events caused by plaque dilatation of highly unstable plaque with high lipid burden when you run this before your angioplasty. So I think is definitely something that may be added to our armamentarium, making even more complex our intravascular ultrasound methodology in the cath lab.
Thank you for this lecture. Now we know the role of IVUS in guiding intervention by giving us data regarding the size of the artery. My question is regarding the accuracy of OCT to provide data regarding the size of the artery compared with IVUS. There is some data that it undersizes the dimensions. Is it true?
Well, definitely there is a difference in terms of measurement if you compare, and the OCT measurements tend to be lower. I think there were various explanations for that. One was that probably at the beginning our calibration method was not as sound as is now with the machine of both vendors. So it was maybe a true mistake of the OCT measurement. The second is, however, more likely that with OCT you truly can delineate the contour, and you can detect protrusion of plaque within stents that are almost invisible with intravascular ultrasound. So you tend to miss the soft component of plaque, thrombus, plaque protrusion, that reduce the true lumen. So in my view, this is the main reason why you have, especially in acute coronary syndrome, differences between the measurement with the two techniques. But the big difference is IVUS is a late assessment done separately by manually by a technician, while OCT has the potential to be fully automated. So that's why I favor the second.
Carlo, it's always a pleasure to listen to you. Could you elaborate on neoatherosclerosis within stents? And is this the cause for the few cases that we see of late stent restenosis that sometimes happens years after stenting?
Yeah, we started to look more carefully to intimal hyperplasia, driven mainly by the late stent thrombosis phenomenon. So what we saw is that in drug-eluting stent, the intimal hyperplasia is often not homogeneous, like in bare metal stents, and that you have areas that may be related to the cellular proliferation around struts. However, by looking carefully, we also found something we didn't expect to see within intimal hyperplastic tissue: calcium and lipids. And disruption of the contours of these plaques that by definition, you may still remember Bernard Meyer saying, well, stent whatever is somewhat narrowed, you will passivate the plaque and prevent progression of disease. It appears that is not such a good idea, because you do have, and you may have, unstable plaques developing with characteristics very similar to spontaneous plaque years after stent implantation. What seems somewhat worrisome is that from both experimental data and some initial OCT series, there is no other method but OCT to assess neoatherosclerosis in stents late after stenting. The phenomenon seems to be to occur earlier and more frequently in drug-eluting than in bare metal stents. However, saying what is the absolute prevalence of the phenomenon, I think is early stage to say, something that has been mentioned and around in the last 1 to 2 years.
Last question. To what limit OCT is preferable over IVUS in patient with renal impairment? And what is there is any particular creatinine clearance ratio that using of OCT is totally safe?
Well, obviously intravascular ultrasound has an edge when you have a renal impairment, because you don't have to inject contrast for obtaining an intravascular ultrasound images. I've done myself some procedure almost completely without angiography, purely repeating assessment and passages with intravascular ultrasound. I could say OCT, definitely you have to pay attention to the amount of contrast you inject. At the beginning it was quite a lot because the pullback was very slow. Now at 2 centimeters per second, if you limit yourself to the segment of interest, you don't really are interested to repeat all the times 10 centimeters of assessment, you can almost have the same amount of contrast injecting at 4-5 ml per second in the left, 2-3 ml per second in the right, that you use for a conventional angiogram. That's why I say 17 pullbacks, but these are in reality 17 angiograms. So the total amount is not that much more. However, I think there is a limit in terms of not really using when you have less than 35 GFR.